Hey, welcome to Simple OT. Today I will be talking about burn rehab. So these are the phases of burn rehab. There's emergent, acute, surgical, or post-surgical, rehabilitation, outpatient, and community reintegration phases. Now, it's important to note that not every single person goes through the surgical or post-surgical phase, right? Because not everybody has surgery. But just know that the emergent phase is the window of 0 to 72 hours after the burn. The acute phase is greater than 72 hours after the burn. And then the rehab phase comes after that, once the wound has closed. And then after that, once the patient is able to go home and is cleared for discharge from the hospital, they begin outpatient and community reintegration. So with the surgical phase, the timeline isn't set because you could have surgery in the emergent phase or acute phase if you needed it. So you might have surgery in the emergent phase if you are doing some sort of stabilization to a patient, or if the patient needs to be stabilized, they might go into surgery immediately. Also, with grafting, you might have that a little bit later. That occurs more so in the acute phase of burn rehab. So the emergent phase. The emergent phase main idea here is that it is an emergency. The goal is to stay alive. This is right after the burn has happened. They're coming into the hospital. Think emergency. So when you're evaluating them, you're going to assess the affected joints and determine if they need OT. You might not be able to do very much in this phase. You may or may not be able to get an occupational profile as well. The patient very well could be unconscious or sedated, etc. For treating, you're really only going to do splinting at the most. For the acute phase, the main takeaway is damage control. So here you're going to be focusing on preventing contractures, promoting wound management, decreasing edema, avoiding infection. To me, these are all things that might happen in acute care. So acute phase. You're just trying to reduce the damage as much as possible. For evaluating patients in this phase, you're going to focus on their level of independence with ADLs. You might assess their range of motion, their pain levels, as well as their psychological state, because they just had a major trauma, right? They could be very distressed, especially if they're in a lot of pain. And for treatment, it's going to be focused around splinting, positioning, and edema management. So, edema management, normally we would think to elevate the extremity if possible and encourage active range of motion, maybe wrap the area. But there's a few things you have to consider here, because if somebody's very burned, you have to consider their positioning, right? You can't flex extremities if they're burned. So when you're positioning or elevating a burned area, really try to avoid flexing other burned areas. So if you see edema in a hand, you don't necessarily want to rush to get a bunch of pillows and prop up the arm on the pillow if the axilla is burned, because if the axilla or armpit is burned, you do not want to allow shoulder flexion or adduction here. Also, with active range of motion, there should be no active range of motion if there's recent skin grafts or tendons that are exposed from the burn. Essentially, just wait for the hand surgeon's blessing here, especially if the hand is involved. Also, with wrapping an area, you can't necessarily wrap an area if there is a humongous wound, for example. So it's more complicated than traditional edema management. So in the surgical or post-op phase, note that not everyone goes through this phase. Superficial and superficial partial thickness burns are largely non-surgical. The main idea here is to maximize function, and the goal of surgery is to promote occupational participation. We want to maximize what we can. So there is an immobilization period of generally 3 to 10 days after a skin graft, for example, but this can absolutely depend on the surgery, the person, the type of graft, the size of graft or burn, and then the location of the graft as well. Really just touch base with the surgeon here, always a good idea to do so. For treatment, you'll be focusing on anti-contracture positioning, gentle active range of motion after the waiting period is over, and then the patient might be in bed for up to a week following a skin graft, just because they're not going to necessarily be cleared for walking right away. So what is anti-contracture positioning? Anti-contracture positioning is the position of the person in the bottom right-hand corner that's floating in the clouds. You'll see why in a second. So the general concept here is to avoid all comfortable positions. Avoid flexion. The person's going to come to you and they're going to want to curl up in a little ball because they hurt. Do not let them do this, because a flexion position or a comfortable position is going to lead to a contracture. We want to maximize the surface area and stretch the body out as much as we can, basically. So to help us remember and visualize what this looks like, I have created an image to the right of the rapture, where I say, in the rapture, we avoid contracture. So if you can remember this silly quote, in the rapture, we avoid contracture, you can visualize being taken up into heaven in the middle of the rapture, arms open, head looking up towards the sky. You are thrilled to be going to heaven, so up you go. The neck will be an extension, the trunk will be in neutral to slight extension, the upper extremity is going to be abducted and externally rotated with some supination as well. The hands will be in the anti-deformity positioning or splinting, and then lower extremities will be abducted to 20 degrees with knee extension and dorsiflexion, because the body is going to want to fight all of this and do the exact opposite of this, and we're not going to let it. So, moreover, with the hands, the anti-deformity positioning or splinting looks like intrinsic plus hand position, which I have a photo of on the right, where the wrist is extended to 30 degrees, the MCPs are flexed to about 50 degrees or up to 70 degrees. The IPs are in full extension, and then the thumb is in a palmar abduction. It's important to note that if the burn is on the dorsal side of the hand, you want the splint to be on the opposite side of the hand. You also want to avoid things like Velcro that are going to irritate the burn. So the image on the right is really perfect to show a dorsal-based splint that also has elastic straps and not irritating, scratchy Velcro straps. So the rehabilitation phase is the phase where we're going to regain function. This is the meat of it. This is OT heaven, because we're going to be doing what we can to rehab this person. The goal is to optimize self-care, and in evaluation, you're going to be assessing or addressing atypical movement patterns. And during treatment, you're going to be focusing on desensitizing the skin, massaging the scar with lotion or sunblock even. You're going to be focusing on reducing edema, introducing compression therapy, and also just more splinting and ADL practice. So what is compression therapy? Essentially, the basics of compression therapy are that you're going to fit them with the garment within 3 weeks from wound healing. You're going to wear the garment all the time, but they can take the garment off for up to an hour for showering or hygiene. And you'll want equal pressure throughout the garment. And what's great about it is it reduces edema and it also helps with scar management. So in the outpatient and community reintegration phase, the main takeaway is to maintain or adapt to promote long-term functioning. The goal here is to live your best life. You're out of the hospital, you're back at home, live your best life. So for evaluation, it's really going to be anything. You're going to be coming into the picture at this point and just figuring out what it is that the client has deficits in and what they want to do here. Be client-centered. For treatment, you might continue with scar management because scar maturation, as we know, can take up to 2 years. You might review some psychosocial supports, maybe explore support groups or relaxation therapies for other burn survivors as well. Community reintegration happens here, so this could look like reentry into the workforce or school or whatever that looks like for the person. They're going to go back to their life. So for some considerations in the evaluation stage, there's the rule of 9s. There's an image of the rule of 9s in the center of the slide. Essentially, it's just a way of marking how much of the body was burned. So if you think of the body as at 100% person, it's 100% overall. It is broken up to different percentages based off the limbs, right? So the head is worth 9%, the arms are each worth 9%, and then the legs are worth 18% each. I'm thinking like 9 in the front of the leg, 9 in the back of the leg, which totally makes sense because legs are bigger than arms. The trunk is worth a total of 36% if you think of the front of the trunk as 18% and then the back as 18%. And the private area will be 1%. And so all of this adds up to 100, and if somebody has burns of more than 15% of the body, it's not good. They should see a doctor because they are risking dehydration, shock, and also could be death if not treated. It's also worth noting that the patient may not have any pain at all in severe burns, so you may ask them their pain scale. They may not be able to tell you. They may also not feel pain with movement, so it's important to keep that in mind because you could hurt them. And they could have multiple burn severities across their body. One area could have worse burns than other areas, and they might also have PTSD or PTSD symptoms here. So definitely screen for that. And for treatment, they may have nerve damage, so you definitely don't want to just like plop an ice pack on them and walk away because they won't be able to feel it, and then there could be injury as a result. If you are ranging them, there might be a hard end feel kind of randomly, which could be a sign of heterotrophic ossification. And with HO, you generally want to encourage active range of motion as the first line of defense here. And lubrication will be your friend. So get the lotion out, get whatever you need, as long as it's cleared by the surgeon at the start of every session. Just give them a good coat. Hydration is our friend. I hope that this was helpful. Thanks so much for listening, and good luck studying.